Hi again, I'm Lennox Hoyte, MD, fellowship-trained urogynecologist, pelvic surgeon, and pelvic floor specialist. And today we're talking about pelvic organ prolapse and what the risk factors are. We may have discussed in an earlier video that prolapse is actually a turning inside out of the vaginal wall, a falling down, if you will, of the vaginal wall. It can go by names such as Cystocele, Rectocele, Enterocele Uterine Prolapse. All that means is that the vagina is falling outward. From being held inside normally, it's falling outward. The biggest risk factor for pelvic organ prolapse is actually vaginal childbirth. So if you push the baby out through the vagina, a vaginal delivery is what carries the biggest risk for pelvic organ prolapse. Many of us believe that the first vaginal delivery carries the highest risk of pelvic organ prolapse due to pelvic floor injury that could be caused by this large fetal head, baby's head coming down through the small, narrow vaginal canal. So what happens in childbirth is this relatively large head, 4 to 5 inches in diameter, is coming down a channel, if you will, the vagina, that normally is about 1 inch to 1.5 inches in diameter opening. It stretches things. The delivery stretches the pelvic tissues, the vagina, the pelvic floor muscles, and many of those tissues will normally come back into normal shape after the delivery, but up to 40% of the time after vaginal delivery, that tissue will stretch enough so that it actually starts bulging outward. So the biggest risk factor for pelvic organ prolapse is vaginal childbirth. Other lesser risk factors include chronic constipation. If you spend a lot of time straining at having bowel movements, that's definitely a risk factor for pelvic organ prolapse. Chronic heavy lifting, if you do a lot of heavy lifting, you work on a farm and you throw around 100-pound bales of hay routinely, for example, that's another risk factor as well. Lesser risk factors include chronic wheezing from asthma or COPD. And interestingly enough, women that jump out of airplanes and land in parachutes tend to have a higher risk of prolapse. It's a very rare condition, not very many parachute jumpers out there, but that can also be a risk factor for pelvic organ prolapse. So when you think about prolapse, it's a bulging outward of the vaginal tissues, usually something that you can see coming out between the labia when you look down there. Some women will even take a mirror and look and strain down and they'll see something bulging out from between the lips of the vulva, and that usually is pelvic organ prolapse. Again, if you've never given birth vaginally, chances of having prolapse are extremely low, but still present. Some people do have those risks, including women that have collagen vascular diseases like Ehlers-Danlos syndrome, for example, Marfan syndrome, and so forth, can be also at high risk even without having given birth vaginally. But the biggest risk factor is vaginal childbirth. So how do we treat prolapse? So prolapse first needs to be determined to be something that's non-life-threatening. Generally speaking, prolapse is not life-threatening. Sometimes it can be if it leads to terrible scarring, if the tissues of the vagina are outside enough that they're getting irritated and infected. That could be a medical concern. If the prolapse is causing you to not be able to empty your bladder very well and causes you to retain lots of urine, that could cause injury to the kidneys. Those are the two big ones. Sometimes if the prolapse is happening as a result of something else going on medically, rarely like tumors and things like that, those can be risk factors, life-threatening. Usually prolapse is not life-threatening. The only way to know that for a fact is to actually have it evaluated by a qualified specialist, usually a fellowship-trained urogynecologist, specially trained gynecologist or urologist, sometimes a colorectal surgeon, or even a pelvic floor physical therapist can help you determine if your prolapse is life-threatening or not. If it's not life-threatening, one of the things you could do is nothing. So you could leave prolapse alone and ignore it safely as long as it's determined to not be life-threatening, and you can put up with the nuisance of the quality of life issues that goes along with it, the urinary urgency, the urinary frequency, the pressure, the low back pain worse at the end of the day, difficulty bowel movements and so forth. If that's something you can live with, most women don't want to live with that, but if that's something that you feel you can manage, you're safe in doing nothing as long as it's determined to be non-life-threatening. Conservative measures for addressing prolapse include placement of pessaries. They're specially shaped rings or other shapes that will go inside the vagina, kind of like an umbrella without the pokes that'll open up inside the vagina and hold the vagina up and prevent the bulging. That's non-invasive. You can insert pessaries and take them out at will, and that works some percentage of the time reasonably well for a number of women. They do have their limitations. You have to take them out if you want to have sexual intimacy, for example, and some women are okay with that and others are not. The other non-invasive methods for addressing prolapse include pelvic floor physical therapy. Sometimes the pelvic floor muscles can be strengthened and rehabilitated enough so that they can close the opening to the vulva enough so that they can hold a prolapse in. So physical therapy can be something and certainly should be tried. It's non-invasive. It is not a cure, but it's a method for keeping the bulge inside most of the time, and sometimes it can work. Once we get beyond that and we're looking for definitive therapy, that's usually surgical, and these surgeries can usually be performed transvaginal prolapse repair, but the gold standard for prolapse repair is abdominally placed graft for suspending the vagina in a way that holds it in place for the long term. This can be very durable. Those grafts can either be synthetic, and we here at the Pelvic Floor Institute have developed a technique for using your own very strong tissue to make that graft and suspend the vagina robotically through the abdomen. That's an extremely successful and durable procedure that does not involve the use of mesh. If you're interested in learning more about our novel techniques for surgically addressing pelvic organ prolapse, come visit our website, www.mypfi.org. If you're interested in treatment, we see women from all around the United States and around the world to address prolapse, and we may be able to help. So give us a call, come visit us, come see us. I'm Lennox Hoyte. Thank you for watching. So usually the biggest risk factor for pelvic organ prolapse is actually damage of the pelvic floor muscles and tissues related to vaginal childbirth. So in women who have undergone vaginal childbirth and put the pelvic structures under tension, those are the women that tend to have the highest risk of pelvic organ prolapse. Occasionally, there are women who have genetic situations that put them at risk for prolapse in the absence of childbirth, but the big risk factor is usually childbirth.